Weight control. Learn more about weight control. Weight regulation, psychological aspects. J. Wardle, in International Encyclopedia of the Social and Behavioral Sciences, 2001. 1. Weight and weight control. Weight and weight control problems appear to be very different at the two extremes. Most obese people are aware of their weight problem and try to regulate their food intake, but often they find it impossible to exert enough control, or to maintain control over a long enough period, to achieve a normal body weight. In contrast, patients with eating disorders appear to exert excessive control over their body weight, successfully defying biological and social pressures to eat. In between the two extremes lies the normal weight population. At one time it was assumed that these would be the normal eaters, that is, not worried about weight and regulating their energy balance without any deliberate effort. However, this view is looking increasingly questionable. In Britain, for example, the proportion of the population who are obese has doubled since the mid-1980s, and concerns about weight control are widespread, even among the normal weight, suggesting that weight regulation is neither effortless nor effective. The normal weight population probably includes a minority who maintain a normal weight without deliberate effort, a larger group, most often men, whose weight slowly increases over time, but who make little attempt to regulate it, and the largest group, in which women predominate, who are chronically attempting to control their food intake in order to regulate their weight closer to the contemporary ideals for body shape. Research into psychological aspects of weight regulation is predominantly in three areas: a. The psychological processes leading to the development of eating disorders, b. The psychological processes leading to obesity, and c. The causes and consequences of dietary restraint. Physical activity, smoking cessation, and weight loss. Weight loss. According to the Weight Control Information Network at the National Institutes of Health, there are two main categories of weight loss programs, non-clinical and clinical. 22 The former may be self-administered or performed with assistance from a weight loss clinic, counselor, support group, book, or website. Non-clinical weight loss programs should use educational materials written or reviewed by a physician or dietitian that address both healthy eating and exercise. Programs neglecting the exercise component should be avoided. Figure 5-6. Although many commercial programs may promote proprietary foods, supplements, or products, these may be costly and will not teach participants about appropriate food selection to maintain long-term weight loss. Programs promoting specific formulas or foods for easy weight loss may offer short-term weight loss because of calorie restriction but should be avoided because they may not provide essential nutrients, do not teach healthy eating habits, and are not sustainable. Clinical weight loss programs are administered by licensed health care providers including physicians, nurses, dietitians, or psychologists in a clinic or hospital setting. These programs may include nutrition education, physical activity, cognitive behavioral therapy (CBT), prescription weight loss drugs, or gastrointestinal surgery, depending on the desired weight loss and health status. Overweight and obesity. Trends in weight control management. Optimal management in weight control is unlikely to come from unlocking a lock with a single key. The appropriate analogy is more likely to be that of a barrel lock, which will not open unless all locks on the barrel are lined up. Some of these strategies are discussed in following chapters. Meanwhile, there are a number of recent developments that can help facilitate the process. Among the more recent are putting the emphasis on lifestyle change, matching strategies to the patient, and combining treatment strategies. Triaging obesity management. Excess body weight can range in medical seriousness from relatively benign to extremely morbid and severe, not always indicated by size alone. As discussed earlier, studies have shown that around 1 in 3 obese patients do not have the comorbid risk factors otherwise predicted by obesity, while around 1 in 4 lean patients can have these risks. Phillips and Perry, 2013. Triaging patients into 3 or 4 categories based on principles such as the Edmonton Staging Model, Sharma and Kushner, 2009, can help locate individuals in categories of response ranging from simple nutrition and exercise programs to corrective surgery or palliative care. putting the emphasis on lifestyle change. With all the hype about new diets, drugs, surgery, and other weight loss treatments, it is sometimes forgotten that every treatment that works requires a lifestyle change involving the energy balance formula shown herein, and that such a change should be the core of weight loss management. That this is often not the case is due to the fact that in a modern obesogenic environment, such a change is difficult to make. More detail on nutrition and physical activity is covered in the following chapters. A structured approach to this is covered in the Australian National Clinical Guidelines on Weight Control and Obesity Management (NHMRC) 2013, and in Egger and Binns 2001. Matching the strategies to the patient. A one-suit-fits-all approach is no longer regarded as acceptable in weight loss management. For one thing, the strategies are complementary. Furthermore, they should be used dynamically such that the strategy or strategy mix implemented at the start of a program may be totally different to that used after early losses or for long-term maintenance. The skill of the clinician is in matching the appropriate strategies and methods within strategies to the patient. Recognizing unhealthy versus healthy body fat. As discussed before, abdominal and particularly visceral fat are associated with greater metabolic risk than gluteal, or lower body, fat stores. Fat cells also have a maximum capacity to store fat, or lipids, which may occur at different levels of expansion in different individuals. Where fat storage reaches its maximum capacity, both through hyperplasia, the expansion of new fat cells, and hypertrophy, the expansion of the existing cell with lipid, see Fig. 7.2, and spillover occurs, excess energy is then stored ectopically, i.e., away from its normal place, in muscle, liver, or the bloodstream. Although it is generally associated with excess abdominal fat, spillover can occur in some individuals who do not appear overweight and not occur in others who are obese, hence possibly helping to explain the healthy and sick fat phenomenon at different levels of obesity. The difference can generally be detected by measuring fasting lipids, which may show raised triglycerides in association with an excess waist circumference, which together are highly predictive of insulin resistance. Arsenault et al. 2010. Combining treatment strategies. Often in the past only one strategy, e.g., drugs, diet, has been applied to any or all individuals. This is now considered to be less effective than combining strategies, at least in the appropriate situation. Medication and surgery, for example, can be used together with meal replacements. Pre-prepared meals can be used with a nutritional education and counseling program, and exercise should always be combined with a hypocaloric diet, which can consist of meal replacements, low-energy meals, or a hunger suppressant drug where indicated. Making a distinction between short and long-term loss. It is now well recognized that short-term weight loss is relatively easy. Long-term weight loss maintenance, on the other hand, is more difficult and possibly dependent on the length of time being obese, but should be the main goal of any effective weight loss program. In the early stages, quick weight losses may be important for increasing motivation to proceed to longer-term benefits. It is much easier to do this at the outset by reducing calorific intake than by increasing exercise output. However, over the longer term, an increase in daily activity has been found to be one of the most significant factors in sustaining losses. Wing and Hill, 2001. From diets to a lifestyle eating plan of reduced energy eating because of the vagaries of physiological adjustment and the difficulty in trying to psychologically overcome a biological drive, hunger. Diets, as in a structured reduction in energy intake, are unlikely to be able to be maintained over the long term. Because going on a diet usually results in coming off it sooner or later, weight regain is likely. And because of feedback mechanisms, this is likely to exceed that which is lost during the energy restriction phase, causing the common tick-shaped response, quick loss but overcompensated weight gain. Consequently, the modern shift is to a change in the pattern of eating, reducing, in particular, fats and other high-energy dense foods and increasing fiber and foods with low energy density. Use of clinically supervised meal replacements. Although they have been around for some time, meal replacements in the form of powdered drinks or food bars have been generally frowned upon because they have not been nutritionally balanced and are often used over the short term only without clinical supervision. Advances in food technology and an increase in clinical knowledge have resulted in an increase in their use under certain conditions. Exert, 2006. Weight management, finding the healthy balance. Exercise for weight management and health. At the other end of the weight control spectrum from diet is exercise. Too much food and not enough exercise, and people will gain weight over time. The opposite is also true: too much activity and not enough food, and people will lose weight over time. Finding the right balance between healthy food intake and exercise is the solution. But it is easier said than done, since exercise is hard work, the way life was before today's convenient lifestyles. Morsel, the sovereign invigorator of the body, is exercise, and of all the exercises walking is the best. Thomas Jefferson, U.S. founding father and president, 1743 to 1826. Exercise is the performance of physical activities to achieve ideal body weight, physical fitness, and health. It boosts the immune system, builds muscles and bone density, develops athletic skills, helps prevent disease, improves mental health and prevents depression, maintains joint mobility, reduces surgical risks, and supports weight loss or weight maintenance. Frequent and regular aerobic exercise may prevent or support the treatment of coronary heart disease, diabetes, hypertension, obesity, and type 2 diabetes. But exercise is only part of the bigger issue, which is physical activity. Cardiovascular disease in diabetes. Weight loss bariatric surgery. Most individuals with T2DM are obese, and weight control has been considered a central component of lifestyle intervention. Weight reduction or at least stabilization in overweight or moderately obese patients will still be an important component in a lifestyle program and may have pleiotropic effects. In severely obese individuals, bariatric surgery causes long-term weight loss and reduces the rate of incident T2DM and mortality. Seostrom et al., 2004. Bariatric surgery induces remission or improvement in T2DM in 40% to 85% of patients. Seostrom et al., 2004, Puzziferi et al., 2014. It is not known whether the remission in T2DM seen after bariatric surgery will lead to a reduction in CV events. Carbohydrate basics, sugars, starches and fibers in foods and health. Over easy. In a time that finds people struggling with weight control, diet and disease, much focus has been directed to individual nutrients and their effects on weight and disease management. Carbohydrates have been in the limelight for their suspected and confirmed roles in obesity, cardiovascular disease, celiac disease and gluten intolerance, dental caries, diabetes, lactose intolerance and metabolic syndrome, among other conditions. No single nutrient causes all of these conditions, nor is there just one nutrient that fixes them. Sugars and starches do not cause overweight, but eating too much of any of these carbohydrates may contribute to weight gain. If not counterbalanced with exercise, these extra pounds may lead to obesity. Likewise, eating too many carbohydrates does not cause cardiovascular disease or diabetes. Rather, they may lead to overweight, which may predispose certain individuals to these diseases. People who are lactose or gluten intolerant are best served by eliminating lactose and gluten, and people who are prone to dental caries should practice proper dental hygiene.